I don't believe that physicians really appreciate the mortality from pneumonia. It's common, and it's the leading cause of infectious death in adults. From an emergency department perspective, it is rare to see simple community-acquired pneumonia, the young person who comes in with cough, sputum, and fever. More and more of these patients are more complex. If it is a young person that's come in, they've usually been on a course of antibiotic therapy as an outpatient already and are failing. But more commonly, these are patients who are very, very complex, tend to be elderly, multiple comorbid conditions, and are high risk for mortality, but also high risk for failure.
If you talk to internists or pulmonary physicians or infectious disease physicians, they know there's a problem with pneumonia. You don't have to convince them. For many of the family docs, however, they don't see it as a big problem. They've got other things on their radar. Given the circumstances that they're working under, it's very tough with just a history and physical to make an accurate diagnosis of pneumonia.
The biggest problem that we have today is that we don't have great diagnostic tests. So most of the time, we're just, kind of shooting in the dark. We're not exactly sure what we're dealing with. That actually makes the treatment of community-acquired pneumonia somewhat challenging. Because you're not exactly sure what you're treating.
The nature of community-acquired pneumonia, how it's treated empirically, probably 90% of the time or even greater, would mean that often we get it wrong. We don't get the right coverage for the patient. They may not respond in the manner that you thought. They could have relapse. They could have reoccurrence of infection.
It turns out in patients who have severe community-acquired pneumonia, you really only have one chance to get it right. If you choose an antibiotic that doesn't cover the pathogen that is causing the pneumonia, or the organism is resistant to the antibiotic that is chosen, the chances are you'll have a clinical failure.
It is one of the major reasons for admission that we see to the hospital, and it is also one of the top causes for readmission within 30 days.
The environment's changed, the bugs have changed. Not the bugs overall, but the resistance patterns have changed, while the antibiotics have not. And so I think more now than ever, it's probably important for people to take another look at pneumonia and take another look at how we're treating pneumonia, as well as being a little bit more thoughtful about how we prescribe instead of just simply looking at a guideline.